have to have a few things we need to kind of finish up for this chapter, and then we're kind of all set for our Unit 2 tests. So what we want to look at is a little bit more about kind of like bone repair and injuries or fractures. Okay, so a fracture, you can classify it in a bunch of different ways. And again, these are really good multiple choice questions. And we're going to use these three things. And a lot of us, we've heard kind of these terms, especially if you've been watching football, where a lot of these are going to kind of happen, where you'll hear them talk about specific fractures. And we just want to make sure we know exactly what they mean when they say these different kind of terms. Okay, so we're going to classify our fractures based on these three things: position of the bone ends after fracture. So they're either aligned or they're no longer aligned. Okay, and we also are going to term this sort of like it's non-displaced, which means they're still aligned, versus displaced, which means the pieces of the bone are no longer aligned properly. Okay, we have completeness of the break. This is a break that's either through the whole bone or only through part of the bone. So if it's through the whole bone, it's going to be a complete break, obviously much more serious. And then if it's just through part of the bone, it's going to be considered an incomplete break. But the good part about those ones is that, the bone is still aligned, and it just makes it where the healing process is going to be a little faster. There's no need to kind of pin things or brace it as excessively. Part three is, do the bone ends penetrate the skin? These are the really, really nasty ones. Okay, so this is called an open versus a closed fracture. If the bones kind of are jagged and they pierce through the skin, obviously you get a lot more trauma, a lot more bleeding. That's going to be caused an open fracture. And if they're still closed kind of underneath the skin, that's going to be called a closed fracture. Okay, so fracture treatment and repair, we want to go through the steps of how does our body kind of fix these injuries. So we can talk about reduction, and this would be the term used where we're going to sort of realign the broken bone ends, and we want to do this sort of before that healing process kind of starts. This is why it's so important to kind of go to the doctor right away if you think you have a fracture, because if the bones are not aligned and you let it go for a week or two, and then you find out that, yeah, it was broken, they're going to have to realign, and they're going to have to sort of, start that healing process over again and kind of disrupt all the healing that's kind of happened. So if we can do this when the bones are closed, okay, so if we have a closed reduction, this is where they can just use their hands. They don't have to surgically go in or make any incisions to kind of put the bones back into alignment. If they have to go in surgically and put the bones back in their proper spot or put a pin in there, a lot of times, this one's going to be termed an open reduction where they have to, perform surgery. Okay, immobilization, this is a cast or traction. Most of us know if we fracture a bone, it's going to be 6 to 8 weeks, okay, for a simple fracture where you're going to be in your cast. This is important to remember, but if you are injure a bone that actually is, a weight-bearing bone, okay, or something that you can't really immobilize, so like your spine, a lot of the bones, kind of like the femur and the tibia, where it's really, really hard, even if you're on crutches, to kind of keep weight up there completely. It's going to take much longer, okay. But the ones where you really can't immobilize them, where you have to kind of move them. That's why like kind of rib injuries take so long too, because every time you breathe, they're going to move, and you're constantly, because you're still bearing weight and you're still creating some motion in there, you're going to again just be disrupting that healing process. Okay, so they can take much longer if they're large or they're a weight-bearing fracture. They can also take much longer due to just poor circulation, which would be more common in an elderly patient. Okay, and then you have, the 6 to 8 weeks is for to have the cast on there. And then again, once I get the cast off there, my body is not finished sort of completing the remodeling phase. It really can take a year to almost 18 months, okay, for your body to kind of completely finish kind of healing it. So a lot of times we think after 8 weeks, oh, we're back to normal and everything's fine. But again, it's going to be a much longer process. And then what you also want to remember is that once that year has passed, or once that 18 months has kind of passed, that fracture is, you're kind of stuck with however it's healed in that time. So this is where that rehabilitation and sort of making sure you get your range of motion back as soon as possible is really, really important. And we'll talk about that in a second here too. So here is my son's little fracture again, and you can see that he ended up having to kind of have a pin in there. But the cool thing about this one is that, he again, I mentioned this before, he basically broke the whole distal part of the radius sort of off where it was no longer attached. They put the pin in. He had his cast on for 4 weeks. They took the cast off. They pulled the pin out. They put him in a brace so that at nighttime, if he was on the couch or he was sitting in his bed and there was no risk of falling, he could take his brace off and he could move it around. And this really made it that by the time that 8 weeks was up and the bone was kind of fully healed, he had a lot of his wrist motion back, and it just made that rehabilitation time much, much shorter. Whereas if you stick something in a cast and you immobilize it for a really long period of time, a lot of times when you get out of that cast, the motion in that joint is going to be really, really limited. So this is one of those things that we've learned, is that you want to sort of safely, keep as much motion in there as possible to kind of speed up that rehabilitation and just that healing process. Okay, so here are our 4 stages of fracture repair. And again, good to know. You want to know just what happens in each stage and how the first one leads to the next one, just like the bone growth. So we have the first thing that happens is that you're going to have this hematoma that's going to form. So blood vessels in the bone, the periosteum, and surrounding tissues are going to be torn. And again, we saw the picture of the bone where you have all those blood vessels and nerves kind of going through all the different parts of the bone. Those are all going to get damaged, okay? And then you're going to start to kind of hemorrhage, or you're going to have a lot of bleeding, okay? But a mass of clotted blood is going to form at the fracture site, and this is called a hematoma. You're also going to have the tissue at the site is going to become swollen, it's going to become painful, it's going to become inflamed, and this is just that whole inflammation kind of process, okay? And this is really just there to keep you from moving it, let you know that, hey, this part is injured, and it's your body's attempt of just protecting it as best as it possibly can. So here is a picture of this formation of the hematoma. So that's number one. Number two is a fibrocartilage callus is going to form, and again, it's going to be very similar to just how we grow bones, where we're going to sort of first fix everything with cartilage, and then we're going to replace it with bone. Okay, so capillaries grow into the hematoma, and phagocytic cells invade the area and begin cleaning up debris. A lot of debris when you have a lot of injury, where there's a lot of bleeding. Fibroblasts, cartilage, and osteogenic cells invade the fracture site from the nearby periosteum and endosteum, and they're going to at this point start to reconstruct the bone. Okay, so collagen fibers are going to span the break, connect the two bone ends, provide a little bit of stability. Chondroblasts are going to secrete the new cartilage matrix. So again, we're going to fix it with cartilage first, and then we're going to start to add the bone. My osteoblasts are going to begin to form spongy bone. Okay, and the mass of repair tissue is now called a fibrocartilaginous callus. Okay, and this is going to splint the broken bone ends together, and again be the start of this sort of healing process. Okay, but again, we've created a little more stability in that joint by doing all of this first. So here is our fibrocartilaginous callus. Okay, so step number 2. Step number 3, we're going to form a bony callus. So we went from a fibrocartilaginous callus. Now we're going to gradually convert that into a bony callus of spongy bone. The bony callus formation occurs until a firm union forms in about 2 months, and that's where we get to about that 8 weeks. Okay, so this is why you have to keep that cast on, protect that area, make sure you don't fall on it, make sure it's as safe as possible for that 2 months or that 8 weeks. Okay, so here is my bony callus of spongy bone. Number 4, we're going to have bone remodeling is going to occur. So the bony callus is remodeled and excess material is going to be removed. So anybody who's ever broken a bone, a lot of times you'll be able to feel that callus, okay? You'll feel that bump on top of the bone, but over time your body's going to kind of try to remodel that, and it's going to remove as much excess material as it possibly can. We're laying down compact bone at this point, and then it's going to resemble the original unbroken region because it responds to the same stresses. So again, your body is going to sort of build that area up, try to make it stronger based on the stresses that area is kind of absorbing, and this is where your rehabilitation comes in. So they talk about, you have this scar, and they talk about having a really functional scar. And the problem that we run into if we just immobilize stuff and we don't use it is that you end up with a sort of a dysfunctional scar where your body just lays down all this scar tissue everywhere. If you sort of go through your ranges of motion, you sort of work on your weight bearing, you sort of make that wrist or that arm or that leg very functional, and you go through very functional exercises, your body will build up that scar accordingly, and it'll make those tissues almost as strong as they were sort of before. Okay, but this kind of tells you that rehabilitation and just getting that motion back and doing all those strengthening things when you're coming back from an injury is really, really, really important. And again, this takes longer than that 8 weeks, right? This is at 12 months, 18 months, depending on how severe the fracture was, or in which area of the body the fracture occurred. Okay, but we want to really end up with just a strong, very stable area that has been repaired so that it's functional and it doesn't kind of continue to sort of give us problems in the future. The one thing that does happen when you do fracture bones is that they're going to be, you're going to be predisposed to a little bit of early arthritis, especially if you get these fractures kind of by the ends of the bones or anywhere near the cartilage. If you disrupt that cartilage, we have a really, really hard time repairing it. So anything by a joint or within a joint is much more serious because that cartilage is going to deteriorate and our body has no way of kind of restoring it, and we're going to predispose ourselves to early arthritis kind of in that area. So another way that it's very, very important to kind of get those muscles strong, keep as much stress off that joint so that it doesn't kind of come back to haunt you later in life. Okay, so here is our bone remodeling and our healed fracture. And then we want to talk about just some common fractures and just make sure we know a little bit of the terminology here. So this would be a comminuted fracture, And the important thing to know about that one is that the bone fragments into 3 or more pieces. Okay, so comminuted fracture, 3 or more pieces. You get a compression fracture, and this is where your bone is going to be crushed. Okay, very common in people that have osteoporosis, where they'll just fall and kind of land on their butt, and they'll kind of have that just quick compression of the spine, and they'll sort of have these compression fractures of their vertebrae. You have a spiral fracture, so this is a ragged break. Occurs when excessive twisting forces are applied to the bone, very common in sports, okay, where your foot is kind of stabilized and then someone ends up kind of twisting you kind of from up top. You'll kind of twist and tear that bone pretty quickly. Then we get an epiphyseal fracture, always very, very serious. So the epiphysis separates from the diaphysis along the epiphyseal plate. So this is when your bones are still growing, okay? But this is a really serious fracture because, again, you can disrupt that whole just growth process, okay? So very, very serious when you're still growing. Anything by the joint line or by that epiphyseal plate is something that needs to be sort of taken care of and sort of repaired as quickly as possible. A depressed fracture, the broken bone portion is pressed inward. So this is a typical skull fracture, and you can see on this one where this is where you get hit with something really hard in your head, and you just kind of get this depression into those skull bones. Okay, and then a green stick fracture, this is always a good multiple choice question too. So when you're younger and your bones are not fully kind of completed growing and there's still kind of a lot of cartilage in there, the bone is going to break incompletely, much in the way a green twig breaks. So if you take a green stick off of a tree and you kind of, you'll bend it and it'll kind of fray. This is the same thing that happens with these green stick fractures, is that they don't snap and they don't break completely. They just kind of fray. So this is common in children, and again, this is where your bones are still growing and they're a little more flexible than when you're an adult. So now we get to the last part of our chapter, which is bone disorders, and we want to take a quick look at osteoporosis. So osteoporosis refers to a group of diseases in which bone resorption outpaces bone deposits. Okay, so we're breaking down more bone and we're sort of making new bone. So bone mass gradually declines and bones become more porous and light. We're going to see a picture here in a second that's a little scary, making them more fragile. We already said they're very vulnerable to any sort of compression fractures of that vertebrae in your spine. So here is a picture of normal bone, okay, and here's a picture of osteoporotic bone. But we can see just from this picture that, this looks like very much more fragile than the normal bone and more prone to injury than the normal bone is going to be. So when you zoom in, it gets even scary to think that people are walking around with bones like this that are so porous. Okay, so here are the risk factors. Postmenopausal women, so the reason for this is that estrogen secretion is going to decrease after menopause, okay? And then we say, okay, why is that important? What does estrogen do for me? Estrogen is going to restrain osteoclasts, and we know that osteoclasts are the cells that kind of break down bones. So it's going to restrain osteoclasts and it's going to promote the depositing of new bone. So it makes us sort of, put new bone down, and it restrains the cells that sort of break down our bone. And when we have this lack of, or this estrogen secretion decreases after menopause, it's going to lead to osteoporosis in older women because, again, those osteoclasts are going to be more active and we're not going to deposit as much new bone as we used to. Here are some other factors. So petite body form, insufficient exercise to stress the bones. Okay, so the more we exercise, the stronger our bones get. Poor diet in calcium and protein. Again, so a lot of this is, again, going to be based on kind of those blood calcium levels. So if your body feels that it needs calcium, again, it's going to take it from your bones and it's going to make those bones a little weaker. Smoking reduces estrogen levels. That's why it's a factor. Hyperthyroidism, diabetes, certain medications will do the same thing. But it can also be due to immobility. Okay, so this comes down to, again, your body remodels and forms your bone based on stress. If you don't put any stress on there, it doesn't think those bones need to be strong, and therefore I don't have as much bone deposited. So when I get to menopause and my body stops depositing more bone and starts breaking down more bone, I have less to lose before it becomes a problem. Okay, so here is our prevention. So you want to get enough calcium and vitamin D while your bones are still growing. Very important. Almost everyone should be taking calcium and vitamin D. You want to avoid alcohol and carbonated beverages. So this is going to decrease your bone mineral absorption and your bone density. You want to perform weight-bearing exercises throughout life. We talked about how a lot of people want to do the water aerobics, which is great for range of motion, but not a weight-bearing exercise. Doesn't make our bones real strong, so we want to make sure we're doing some exercise, if possible, that's weight-bearing. And this is the most important thing, is that through this exercising throughout life, you want to increase your bone mass above normal value. So we want to make our bones as strong as we possibly can when we're younger, and then this gives us a greater buffer against that age-related bone loss as we get a little older. Okay, so the key is once it starts to deteriorate, it's hard to kind of get it back to normal. So we want to make sure we have a lot built up so that we have more to lose before it again becomes a problem. So here is another picture again, just to kind of show you how serious it is. Here's our normal bone, and then here's our osteoporotic bone. And then if we zoom in, we don't want to be walking around on femurs and tibias and our pelvises and our vertebrae with all this little porous bone, because again, it's going to make us much more vulnerable to injury, and it makes it where we're not able to be active as we get older, which just kind of speeds up this whole process. Okay, so that's the end of chapter 6. So we've covered kind of all the material for chapter 6, chapter 7, chapter 8 for our unit 2 exams, and those are coming up this week.